So the way we're doing genetic testing now in skin cancer can be thought of in two ways. First of all, we have very specific tests on individual genes that we do, particularly to select therapies for patients. And of course, the best example of this is BRAF in melanoma. But we have other important targets as well. There's NRAS mutations, which are now beginning to direct therapy, particularly on clinical trials with MEK inhibitors and other novel therapies. And then also KIT mutations, which we've known about for some time, but do form a part of our treatment planning for those specific mutations. Perhaps though the area of greatest innovation is to think about genetic testing of tumours across large portions of the genome, and particularly to look at the total mutational burden, the number of single nucleotide variants or base pair changes in the coding regions across the genome. And this is turning out to be very interesting because there's some interesting clinical biology associated with highly mutated tumours. They may respond better to immune checkpoint inhibitors, and so potentially this large-scale sequencing of many genes may be a diagnostic as we go forward in optimising the selection of therapies for individual patients. I think ultimately one of the very exciting things we've heard about at this meeting is the very interesting concept of personalised cancer vaccines, where one could sequence all the coding regions of the genome, find neoepitopes, mutated antigens that are unique to the tumour, not shared with other tissues in the body, and develop a tumour-specific personalised vaccine, which I envisage will need to be used in combination with anti-PD-1 therapies as an interesting new approach. So what we're seeing is a transition from looking for individual genes, mutations, selecting therapy, more towards understanding all of the genome. And when will this be ready for prime time in clinical practice? Look, I think within the next 5 years we'll really know how important these multiple genetic events that occur in UV-induced skin cancers are to our clinical practice, beginning with melanoma, but I think importantly squamous cell carcinoma of the skin, Merkel cell carcinoma and basal cell carcinomas all have very high UV mutational loads, and this technology of sequencing all the genes may be able to be used there as well.